Patients with atrial fibrillation not uncommonly have coexisting coronary disease, so the clinical scenario is a common scenario. Previously, clinicians needed to make a decision if the patient was on warfarin and then had a stent placed. Were they comfortable with triple therapy? So that would include warfarin, aspirin, and clopidogrel. A number of years ago, the WOSH trial was conducted, and that provided much needed information for clinicians where the data suggested that warfarin plus clopidogrel as mono antiplatelet therapy was both safe and effective for patients with atrial fibrillation who had received a stent. Now in the era of the novel or non-vitamin K oral anticoagulants, the question becomes if a patient with atrial fibrillation is on Rivaroxaban or Apixaban, Edoxaban, dabigatran, what are the options? Now, Pioneer AF focused specifically on that question in patients with atrial fibrillation who required a stent, and patients were randomized to 3 separate arms. Arm 1 was Rivaroxaban at a dose of 15 milligrams daily, plus a P2Y12 receptor of the clinician or the investigator's choice. Could be clopidogrel, could be prasugrel, could be ticagrelor. Or 2.5 milligrams of Rivaroxaban twice daily, plus dual antiplatelet therapy. So aspirin plus a P2Y12 receptor antagonist of the investigator's choice. Or more traditional triple therapy, that is warfarin, aspirin plus clopidogrel. Those 3 groups were compared, and the findings were interesting, and they suggest that those 2 arms with Rivaroxaban were safer in terms of major bleeding using ISTH, Gusto, and other types of bleeding scales. They also suggested that there was not harm, and the 2 areas that clinicians, I'm sure, are particularly interested in is with either of those first 2 arms of Rivaroxaban, would there be a signal of a heightened risk of either stroke or stent thrombosis, and there was not. The takeaway message is, based on this trial of 2,000 patients, is that it appears that there is a better safety profile with either of the Rivaroxaban arms, not evidence of clear harm. However, the trial was not powered for efficacy, and therefore additional information will be required. For patients that we consider new starts, so someone is newly diagnosed with atrial fibrillation or atrial flutter, the new oral anticoagulants are more likely to be used as compared with warfarin. If that individual then requires a stent or has another indication for antiplatelet therapy, clinicians are really asking for more information. So Pioneer AF, while not giving us all the information about the efficacy, gives us important information on the safety side. And you say, well, what are the alternatives? Well, I guess one could take the person off one of the new oral anticoagulants, put them on warfarin, and that becomes particularly complicated. So
that's actually been getting done, though, you told me.
That has been occurring because we just haven't had the information to guide clinicians. So I believe that the information from Pioneer AF is helpful. It does start to build a platform that clinicians can then be looking at carefully as additional trials are conducted. But this is the beginning, and we needed to start somewhere. The question about where aspirin fits in. As you know, it's been the mainstay of treatment, but also it was almost unthinkable a decade ago to configure a trial in patients that had coronary disease without using aspirin. Now we're exploring that because we have more potent platelet antagonists, we have more experienced operators, we have newer generations of stents, and we know with confidence that when you start stacking antithrombotics on top of one another, what you get most of the time is not greater efficacy, but greater risk of bleeding.